All right, thanks, and welcome everyone. So I am pleased today to, first of all, my name is Jenny Tender, for those of you who don't know me, and I am pleased today to welcome Dr. Ann Kellams as a speaker for today's Grand Rounds, and it's sponsored by the American Academy of Pediatrics section on breastfeeding. So Dr. Kellams has a fondness for outstanding public state institutions. She completed her undergraduate degree at UT Austin, her medical degree at UCSF, her pediatric residency at UNC Chapel Hill, and is currently associate professor in the Department of Pediatrics at University of Virginia. Dr. Kellams is a board-certified lactation consultant and has served as a medical director of the UVA Wellborn Newborn Service for 9 years. She founded the Breastfeeding Medicine program at UVA 4 years ago, and she's a scientific advisor for the online breastfeeding friendly consortium, bfconsortium.org, and is a Virginia AAP co-chapter breastfeeding coordinator. So Dr. Kellams is a fellow of the International Academy of Breastfeeding Medicine, serves on its board of directors, and teaches its annual course, What Every Physician Needs to Know About Breastfeeding. Her research focuses on prenatal breastfeeding education, the use of social media for safe sleep and breastfeeding, and the effects of a breastfeeding-friendly office practice on breastfeeding rates. So becoming more knowledgeable about breastfeeding is important not only for medical students, residents, nurses, but also for pediatric specialists, from the ENT doctor who helps the tongue-tied breastfeeding infant to the gastroenterologist studying the microbiome. So I truly appreciate all of you for coming here and for attending to today's Grand Rounds. I want to warmly welcome Dr. Ann Kellams, who Rachel Moon, who, by the way, was stolen to UVA, once described as absolutely fabulous. And she's going to share with us her thoughts on the pediatrician's role in helping mothers achieve their breastfeeding goals.
I'm going to try this thing because I move a lot. There's a button. Is that on? Yes, you can hear? Okay, great. I'm so excited to be here. Thank you very much to Jenny for having me. Thank you to the American Academy of Pediatrics section on breastfeeding for sponsoring this event. As she said, I'm here to talk about the role that we all have as healthcare providers who work with children in supporting breastfeeding. And the important thing on this slide is helping mothers achieve their own feeding goals. I don't have anything to disclose, except I do work for the online CME and Part 2 and Part 4 maintenance of certification credit that's funded by the Virginia Department of Health. I do not accept any funding from the makers of breast milk, so that hopefully you will find this to be a fairly unbiased talk. So do any of these sound familiar? A mother states that she wants to bottle feed her baby, or she's going to do both when asked how she plans to feed. Or maybe the mom's having challenges. She's sore, the baby has weight loss more than expected, and she really thinks that at this point she needs formula. We're going to talk about why breastfeeding support is important. I'm going to show you some things that I've found to be very useful clinical tools about how to determine if supplementation is needed, how to prevent the need for supplementation with formula, and if formula has to be used, how to preserve breastfeeding as best we can so it's not then the beginning of the end. Also going to talk about how we can all be more breastfeeding friendly in our practice, regardless of the environment. So back up about 4 or 5 years ago, I had been the medical director of the newborn service for about 4 or 5 years at that point, and really struggling with getting our rates up. We signed on to we decided that if we can't go baby friendly, we're going to get as close as we can. And we said, well, let's start with a big staff training. So in order to do that, we had a nutrition intern who helped us put together a needs assessment, and we surveyed our nursing staff on the maternity unit, pediatricians, family medicine physicians, residents, the nursing staff, and then same group in the NICU. And what we found is sort of embarrassing, but that 80% of our staff, our physicians and nurses, had no formal training. We defined formal training as learning about it in medical or nursing school, learning about it at a formal session in residency or training, or attending continuing medical education events. 80% said no. So we had a lot of work to do. We all know the common goals of all of these organizations featured here is exclusive breastfeeding for around 6 months, continued breastfeeding for a year, and when you're talking about it, it's really, I think, better to say breastfeeding for a year and only your milk for 6 months, because women hear the first thing that you say. But why? We know that there's lots and lots of substances in breast milk. It's not just nutrition, it is a support system for new babies. So thinking of it in terms of the best protection for new babies. I'm not going to spend a lot of time today going over the evidence behind breastfeeding and why it's important, but I will say that starting about the mid-2000s, there has been an explosion of all sorts of data coming out about breastfeeding. It started with this report, and this is a busy slide. This is the Agency for Healthcare Research and Quality, AHRQ, 2007, and what they did, which was different than some of the studies before, they said, what about in developed countries? Clean water supply, access to medical care. What do we know about breastfeeding and outcomes for mothers and babies in developed countries? They took tried to get, these are all observational, you can't ethically do a randomized controlled trial of breastfeeding. You're going to breastfeed and you're going to formula feed and we're going to pull out of an envelope which one you're going to do. It's not possible. So these are observational, but to the best of their ability, they controlled for the potential confounders. And you'll see this is AOM, which stands for acute-otitis media. Anything to the left of 1 is protective. Anything that crosses the line is not statistically significant. GI infection here, asthma with a family history, more protection than asthma without a family history. This is obesity in childhood, type 1, type 2 diabetes, leukemia, and by the way, there was just this past year a meta-analysis looking specifically at childhood leukemia, also showing a protective effect, and then sudden infant death syndrome. So something's going on here, and it looks like it's important. We also just returned last weekend from the Academy of Breastfeeding Medicine's international meeting in Los Angeles, and we saw presented white matter changes on the MRI that even when controlling for mom's IQ and socioeconomic factors were improved myelination in the breastfeeding babies' brains versus formula feeding. There's lots and lots of data coming out about the gut microbiome. So suffice it to say, this is important for babies. How about for mothers? Again, going back to the AHRQ 2007 report, BC stands for breast cancer, and OC stands for ovarian cancer. So a protective effect is observed for both breast and ovarian cancer. The breast cancers in these moms tend to be the ones who are premenopausal, younger, the more aggressive types of breast cancer. Melissa Bardick, who is a colleague and friend of mine up in Boston, did a study looking at, well, what if we took the 2007 AHRQ data and 2007 healthcare dollars, and we could get 90% of families to meet the recommendation of exclusive breastfeeding for 6 months. They estimated in their study that $13 billion a year would be saved in the United States, and in excess of 911 deaths could be prevented. So we're really transitioning now from analysis to action. Here's a little bit of a timeline. In 2007, the Centers for Disease Control began surveying all hospitals that provide maternity care throughout the country, and looking basically at how closely they followed the evidence-based best practices, which we're going to touch on. In 2009, the American Academy of Pediatrics formally endorsed those 10 steps. In 2010, the Healthy People 2020 goals were formed, and they basically took all of the breastfeeding metrics for this country and increased the goals. 2011, Regina Benjamin, our Surgeon General at the time, her very first call to action in her office was a call to action to support breastfeeding. In 2012, NICHQ, which is the National Institute for Children's Healthcare Quality or something like that, got a very large sum of money from the Centers for Disease Control to help 90 hospitals in this country, focusing on areas of the country with the lowest breastfeeding rates, become baby-friendly certified. University of Virginia was one of those, and I'm pleased to say in July, this past summer, we were certified baby-friendly. And in 2014, the Joint Commission, whereas prior to that, they had a metric monitoring exclusive breastfeeding in all birthing hospitals for the well newborn population, made that a mandatory as part of their perinatal core measure set. So we're going a little bit further away from Coke, Pepsi, what do you think, lifestyle, personal choice, to this is a health decision. And as pediatricians, we are masters of this dance between giving information and supporting and empowering. So one of the things I want you to take away is that this is about information and making sure there's a true choice, not a controlling, you must do this kind of a thing. But we are going now from not just this is a good thing to do, but what is our responsibility? You can't just say you need to breastfeed, but then not be doing the best practices in your hospital and not be providing access to lactation assistance after the hospital and not be providing community resources or be recommending formula use against the science-based recommendations. So going from not just promoting but to supporting, what is our role in that? We're looking at the environment, we're looking at policy changes, and more of a shared accountability instead of just it's on the mom. So what are the breastfeeding rates in this country? This is a little bit of a busy slide, but I've circled the thing that I want you to focus on here. So exclusive breastfeeding at 6 months, which as I said, the recommendation from the AAP, from ACOG, AAFP, CDC, Surgeon General, we're failing miserably in this country. And if you think about our initiation rates going up to near 80%, and now we think they're just above 80% for the country, 80%, 4 out of 5 mothers come into the hospital planning to breastfeed, and less than 20%, 1 in 5, meet that goal. So I want you to think about that. What's going on? How about who's using formula in the first 2 days? In the past few years, this is another metric that the CDC has added to their breastfeeding report card. And again, I've circled this blue color here. So we're still, and you can see if over time this seems to be rising a little bit, 25% of breastfeeding mothers in the first 2 days are already using formula. The Healthy People 2020 goal, they're setting for 14%, so trying to decrease that number. The blue dots are the District of Columbia WIC participants, and thank you to Jenny for providing me this information. Around 2004, 80% of breastfeeding mothers who were in the WIC population here in DC were using formula before the hospital, and that has since come down to more like 40%. So a long way to go. If you're not familiar with the 10 steps, these are from the World Health Organization and UNICEF. They were put together in the early 1990s. There were some countries in Western Europe that within 4 years, all of their hospitals were certified baby-friendly. I mentioned to you the American Academy of Pediatrics endorsed these in 2009, so we're behind the 8 ball in some sense. But in particular, sorry about that. In particular, I just want you to look here, number 6, no food or drink other than breast milk unless medically indicated. And also, an important thing there is as long as mom is educated, she's able to pick to use formula at any time during this process. So it's not that you can't, it's not that you don't stock formula, it's just that our goal is to only use it for medical indications. So here's a mom, she's admitted, or let's say you're meeting her in clinic, and she says she's planning to bottle feed her baby. What should you do? Is the discussion over, or is there anything that you as a healthcare provider can do? Any ideas? Here's some language that I want you to think about trying. Tell me what brought you to that decision. Have you considered putting your milk in the bottle? Asking and then listening is really the only way you're going to find out what she knows. Maybe you could say, what have you heard about breastfeeding? She may have heard nothing at all. We did a survey around the same time when we got that staff information from our hospital, and we asked women who delivered, Did you get any breastfeeding education from your nurse or doctor in the prenatal clinic? 10% at that time said yes. So she may have heard nothing that's based on science. She may have heard only myths. Sometimes I ask the question, she'll say, oh, well, I want to breastfeed, but I can't because I'm going back to work at 6 weeks. Well, maybe we could talk about partial breastfeeding, or maybe we could talk about just providing colostrum, or maybe we could talk about expressing her milk when she goes back to work, or getting it going now and then making the transition. And many of the studies show that any breastfeeding is better than no breastfeeding. So start a dialogue. Do you know why your milk is good for your baby? Have you heard all of the information that we have now? Do you know what's at stake as you're making this decision? Your body makes things specifically for your baby based on the environment that you both share that you can't put in a can. And then finally, I think a very important line is, I want you to feel comfortable feeding your baby. So tell me what it is about that you like. Making sure that they feel very, very supported, but that it is an informed decision. I sometimes tell my nursing staff, you know, if mom who just had a C-section 4 hours ago is ready to hop out of bed, she's just going to go for a jog around the unit a couple times, we'd be counseling her on why we don't think that's a good idea and that we really don't think she should do that. And it's the same thing. We know all about informed decision making. So this is a graphic from WIC. We have this posted on our units, and nurses have a pocket card. And it's just a visual of, these are the things you can put in the can, and then things like antibodies, hormones, antiviral agents, anti-allergy agents, parasitic growth factors. It has been shown that human milk in the infant's gut sets up an anti-inflammatory milieu. It sets up the baby to become tolerant to foreign antigens rather than responding in a way that sensitizes them to foreign antigens. Lots going on, again, that you can't put in a can. So you may all be familiar with motivational interviewing, but that's the exact same technique that I like to use and I like to teach residents and students and people who come through our breastfeeding medicine program, that this is an exchange. It's not just you need to do this or you should do this or you shouldn't do this. This is, what do you know about this? How can I help you make the best decision for you? If you're not familiar with this website and or you feel a little uncomfortable having this conversation or making a recommendation, I highly recommend bestforbabes.org. It's where I've gotten a lot of my language. This is a nonprofit that's dedicated to changing the perception of breastfeeding, and their whole goal is to eliminate the booby traps. One of the booby traps is lack of prenatal education about this and lack of realistic expectations. One of the booby traps, unfortunately, is delivering at a hospital that's not practicing evidence-based support, or going to a pediatric office after delivery that is not providing evidence-based recommendations for when formula is necessary. So they want every mom, and they say she deserves to make a truly informed choice and then be supported in whatever that choice is. And don't assume anything. This is a great picture of a mother with a baby in our NICU. She has a tattoo of a baby feeding a bottle, and she had formula fed her first baby. This baby was born a little premature, and she was compelled by the stories that they were telling about all of the added benefits for premature infants. She started pumping, and this is the first latch on in our NICU, and she went on to successfully breastfeed. So don't assume anything. So here's our next case. Mom of a newborn has been exclusively breastfeeding, but now, let's say it's the first few hours or the first few days or the first few weeks, she's worried about her supply and she thinks she should start formula. So what do you think? Nope, you shouldn't use formula if you're breastfeeding. Does not work, because what's going on with her? Well, we don't know until we ask, but she's probably worried about something, right? So just tell me what's going on. Tell me what you're worried about. And sometimes we'll hear, oh, well, I don't have any milk yet. And guess what? You're not going to feel the changes of lactogenesis stage 2 in the ounces of milk until day 3 to 5. So if she's not feeling a difference right now, that may be really normal, and maybe she didn't know to expect that. So let's talk about that a little bit before we decide. Or maybe the baby's been really fussy, and she's one of those moms that you walk in and you're like, see, he won't stop crying, and she's holding him on his back, flailing around, and there's no bouncing or motion or patting or anything that babies really like, and she's, you know, deer in the headlights. Or maybe she's worried he's not getting anything. So let's look at the weight. Let's look at the output. I will sometimes say, listen, I don't want him to get dehydrated or starve either. We're in this together. Let me look at all the things that I know can help me assess that and check his exam, and then we'll see how things are going. In the first few days or hours when we're seeing babies in the hospital, about 10 drops of colostrum is a meal because it's concentrated breast milk. So figuring out what her concerns are and seeing. And then if she decides to use formula, mentioning that, you know, the only problem with that is that when you start formula, it can sometimes make it harder to get breastfeeding going. So a failure to me is not a mom who chooses to use formula making an informed decision. A failure is a mom who wants to breastfeed. That's her goal. That's what she came in wanting to do. She gets to that panic worry stage, which I, even as a third-time breastfeeding mother, my husband's a doctor too, I'm a lactation consultant and a pediatrician, I'm like, do you think he's hungry? I mean, we all go through that, you know? And so she's in that moment, and if you go, here's your six-pack of formula, and she walks out the door, game over. She's not going to get that back. If you say, on the other hand, okay, I hear what you're saying. How about if we do this? What if it's a small amount just to tide you over, and then we also have you pumping so your body's not getting behind in signal, and why don't you think about doing it with a syringe or a cup or a spoon instead of an artificial bottle nipple? So just seeing where along that way, again, with motivational interviewing, you can get her. Talking about the supply and demand nature of production is helpful. I will say to moms, if you give your baby formula right now, then yes, his tummy will be full, he's going to feel fat and happy, probably not want to eat as frequently today, probably not be as vigorous at the breast today. And what's your body thinking? Your body thinking, we're making the perfect amount. Baby's not hungry, he's not coming back to the empty breast, he's not rooting a lot, he's not eating frequently, and that tells your body to stop making as much milk at a very crucial time when you're trying to ramp things up and make more. So talking about that, another thing to mention would be, you know, the bottle nipple, and I sometimes will take one and just hold it over, it starts dripping, or you can barely compress it and it starts dripping. What does the baby need to do with the breast? Get there, get oriented, root around, open very wide, start suckling, because we don't walk around spewing milk everywhere. There has to be a mechanism for the body to go, oh, wait, the baby's here, okay, I'm going to go ahead and start releasing that milk. It's called the letdown reflex. So babies, I don't want them to get used to being, I'm hungry, just waiting for something to happen. Are there babies that can go back and forth from the bottle to the breast very easily with no trouble, not looking back? Absolutely. Do you know you have one of those until there's a problem? Absolutely not. So really trying to stay away from anything that has them doing anything else as they're imprinting what feeding looks and feels like. We want them to have a similar experience to the breast. What happens if you use formula? Well, there's a possibility of cow's milk protein allergy with exposure as little as 40 milliliters, which at our hospital prior to baby friendly in these 10 steps was one feeding. We know that there's instant changes in the gut microbiome, but the biggest thing is you are less likely to return to exclusive breastfeeding. It's the strongest predictor. And I have here just a few studies for those of you that want to take this back to your sites. Most significant predictor of duration was whether or not they got supplements in the hospital. That's Cindy Howard in Rochester, and that was regardless of whether it was a medical indication. Shorter duration, 6 times more likely to be exclusively breastfeeding from the New Jersey PRAMS data if they did not use formula in the hospital. And this very large study from pediatrics from the Infant Feeding Practices study by Perrine, only not receiving supplemental feedings remains significant for mothers reaching their own feeding goal. So what can we do to prevent this need? Because we all know it's not as simple as that one conversation when mom asks, right? How can we lay the groundwork? What policies and practices can we be doing to help? So one thing is early and ongoing evaluation. Watching the baby feed. The American Academy of Pediatrics says that in the hospital, this should be happening at least twice daily and documented. but observing the position, the comfort, the activity of the baby. Are you hearing swallows? How's the weight? How's the output? Thinking about this on a sort of twice-a-day basis for those first few days and weeks until the milk supply is well established. Watching a feeding in our electronic medical record, we have EPIC. I don't know what you have here, but the latch score is embedded. There are some other validated tools out there. This one is easy because it's like an APGAR score, and the letters stand for what you're looking at. So are the lips splayed? And you can get 0 to 2 points for that. Are you hearing audible swallows? Not at all is a 0. All the time is a 2. Intermittent is a 1. Type of nipple, is mom's nipple everted or flat or inverted? C stands for comfort, and one of the very important points about this, you cannot do a latch score without asking mom, how does that feel? I don't care what it looks like on the outside, but if she's having a pinchy sensation, we've got to adjust that angle to get the tongue behind the nipple. Any compression, pressure, squishing, or lip sticking of the nipple is the tongue against the palate, and we've got to change the angle of that feeding. So C is for comfort, and then H is for hold. How much did I have to help her? Is she one of those moms that's like, yeah, I don't know what to do, help me? Or did she do everything and I made one little tweak at the end for 2 points? And that's what that looks like. So nipple should be closer to the nose. It is not a target sign, and I think I have a picture here. When baby is coming to the breast, you want to think about tongue and lower jaw coming back here. So we used to say, oh, you need to cover as much of the areola as possible with the baby's mouth. That's not exactly true because the nose is going to be very close to the nipple. So you may see lots and lots of brown here, but the chin should be buried to where you'd have to look for it like this, the nose barely touching. So this is not a target sign. And women who are using their left brain and thinking about rules and thinking about must feed baby want to line up that baby's mouth. I talk about cave woman. Cave woman lying in the cave, baby's on top of her, rooting around, has to bob their head to come to the breast. And that's exactly what we're trying to mimic in what we think is breastfeeding, which is in a rocking chair with music playing, and we're trying to recreate that. So what else? Well, one thing you can do when you're thinking about how to prevent supplementation is look at, well, the women who start out breastfeeding, why are they stopping early? Why are they not meeting their goals? And these are the most common concerns. And as someone in breastfeeding medicine and who's a lactation consultant myself, when I look at this list of latch, milk flow, milk supply, poor weight gain, these are all things that we can help with. But we've got to catch it before they're a problem. So what is the anticipatory guidance that I give? Hopefully these slides are going to be available because I don't want to read them all to you, but basically know your nipples and breasts. All nipple and breast types can breastfeed, but if you have flat or inverted nipples, that angle is going to be even more important to make sure the tongue is not doing damage as that's getting pulled forward. We talked about supply and demand, the frequency of feedings, feeding on cue, trusting your body. I'll say your body is growing or has grown this beautiful baby, and you did not have to go in and say, okay, timer went off, now I'm going to do the fingernail on the right hand on the 4th finger. You know, your body knows what to do, the baby knows what to do. Trust this process just like you trusted your body to grow this beautiful baby. Talk about rooming in, keeping your baby with you. It's been shown that moms learn feeding cues faster. They go home with less anxiety about the infant's crying because they've already learned what to do about it in the hospital. So keeping baby in a separate sleep space but in the room in close proximity to mom is best for her and for baby. Listening to pain. If you're mommy cow out in the field and baby comes up and does something that hurts your udder, you go and walk away, right? You're like, no, stop. And teenagers are really good at this when they're breastfeeding. You know, the pain is a signal that something's going on that we need to adjust. So encouraging moms to keep adjusting. If that's not working, then raise your hand, get lactation, call these resources that are available to you because we want to, quote, nip that in the bud, and pun is intended there. Another thing, talk about normal baby behavior. Really awake for 3 to 4 hours after delivery, very important time to do a lot of feeding, particularly in the first hour, and then usually a sleepy day. And then for the next couple of weeks, awake more at night, feeding more at night. Babies sleep an average of 16 to 20 hours a day, but it's not in the same pattern that we think of as sleeping as adults, right? So really getting moms, you're on the night shift now. This is a 24-hour cycle. Those naps are going to be important during the day, and I don't know what exactly the challenges are of the population that you see, but we see anything from, well, Dad's on the night shift, so I'm doing this, and then my mom comes and helps me and blah, 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 to I've got to write all these thank you notes, and I have all these people that want to come see the baby, and I want them to come. So helping the family in front of you manage how are you going to get some resting time during the day, knowing that the nights are going to be with frequent wakings and feedings. I put Supermom here because the message you want to be sending with all this anticipatory guidance is you've got this. We're here for you. We're going to help. This is going to be good. Following weight, this is a very interesting study that was done in a baby-friendly hospital. So evidence-based, best practices, best breastfeeding support, and the exclusively breastfeeding babies lost an average of 5.5% for their nadir of weight. The Newt study, which came out this past year, I'm going to show you. If you go to newbornweight.org, it's a very neat tool that in the first couple of days you can enter what was their birth weight and time, were they vaginal delivery or C-section, are they breastfeeding or formula feeding, and then it'll give you a graph and show you exactly where those weights plot. And interestingly, this is a very large study from Kaiser, 100,000 babies, not all baby-friendly hospitals, not all best practices. So this is sort of normative data for that population. It's not necessarily what's safe, but you can see that the mean on day one, right here, was 4% weight loss. We used to say anything more than 3% a day is abnormal and could be a reason to start intervening. Probably not. And these are all babies that did not go on to develop jaundice and need phototherapy or get readmitted for weight loss, so they excluded babies that had problems. C-section babies, day one, 7%. So it's been shown that the more IV fluids a mom gets before delivery, the more weight they lose after delivery. So we may be artificially making that birth weight higher than it really would have been had they not had to have that medical intervention. So practical guidelines, we usually say at least one void for every day of age, and I think that holds true. At least one good stool per day. Remembering that 10% down does not mean automatic supplementation, but it absolutely means what's going on here. Are you having any soreness? How often is the baby feeding? Anything else that's going on? Can I help the baby transfer milk? Can you be hand expressing or compressing while the baby's at the breast? What kinds of breastfeeding management can we do to help turn this bus around? If they're still continuing to lose weight after day 5 to 7, then I'm starting to get interested, or not back to birth weight by around 2 weeks, certainly by 3 weeks. And really the whole time, these are markers for more investigation, and we're really trying to say, is this dehydration, starvation, or is this just a baby who we need to turn this bus around before it gets there? We have these posted in all of our rooms, and we also have them laminated in the clinics. It's just a nice visual for what I was talking about. So tummy size, tiny, and then getting bigger, bigger, bigger over the first couple of weeks, the amount of diapers we expect, when the stools change colors, and the message that healthy babies wake often and feed frequently. So when should you supplement? I'm not going to go through all of these, but the main point here is the Academy of Breastfeeding Medicine has a very nice, very well-referenced evidence-based protocol for what are the infant indications. And the important thing to know here is that whether it's hypoglycemia or dehydration, whatever the medical issue is, you only would use formula if the appropriate breastfeeding management after a thorough evaluation was not enough to help you turn things around. So it's not 10%, it's clinical and laboratory evidence of dehydration. Also, you can't make the diagnosis of delayed lactogenesis stage 2 or insufficient milk production until day 4 to 5, when mom then would be experiencing the engorgement and the transition to ounces of milk. The other thing I use when I'm talking, I never say when your milk comes in, because that underscores that fear that I don't have milk now and nothing's happening. So we talk about concentrated drops of breast milk transitioning to ounces of milk, and we're going to be here with you to make sure that's safe during the transition. With jaundice, I just heard Dr. Butani speak at the AAP meeting, and he said breastfeeding is not a cause of jaundice. Poor breastfeeding is a cause of jaundice. So again, proper management of jaundice, our rates of phototherapy have gone down because we are supporting infant intake and nutrition better by having implemented these evidence-based practices. So really only if you're like, whoa, even though I think you're hydrated, you're getting close to exchange level, probably because of underlying hemolysis, or if we think, wow, you know, I'm needing to start phototherapy, and I think this is because breastfeeding hasn't been going well, and I'm trying to turn that bus around and it's not working. Those are the only times we would use formula. For moms, again, a delay in lactogenesis, you really can't make that diagnosis until the baby is a few days old. But things like, does she have a retained placenta? Is she having more bleeding than normal or expected? Did she have postpartum blood loss? And could there have been a little hit to her pituitary? And then really, there is something called primary glandular insufficiency, very uncommon in the population. We're talking on the order of 2 to 5% or less. But if you have a mom who is not transitioning to ounces of milk, does not report changes in her breast size or enlargement during pregnancy, did not have tenderness, maybe her breasts are sort of a tubular, wider space shape with insufficient glandular tissue, that could be a situation where then you're looking at what % of milk can you make for your body. But that's 2 to 5% of the population, but if you did, I bet you anything, did a poll on the street, how many women do you think can't make enough breast milk? We'd probably get, what do you think, 80%, 70%? It is way less common than what is commonly talked about. If she's had surgery, that is not a contraindication to breastfeeding, but again, we don't have that cushion of baby can eat whenever they want and do any signaling. I'd be having her hand express or pump or do something in addition to what baby's doing from the start so that we can maximize her potential and see what % of milk she can make for her baby. And then sometimes things are so bad by the time they come to your attention that they just have to use something else for a couple of days of healing. Hopefully we'll be preventing that. If you have to supplement, it's actually, the Academy of Breastfeeding Medicine goes on to say, well, first try mom's own milk. So if baby's not transferring it well or not draining the breast well or there's drops or ounces in there the baby's not getting, get them out for them with a pump or hand expression, give them to the baby. That's first choice. Pasteurized donor milk would be the second evidence-based choice, followed by a hydrolyzed formula where the cow's milk protein has been broken up so much that they're less likely to develop sensitivity, followed by standard infant formula. So again, that's flipping on its head what we have traditionally done, but it's something to think about. Preventing breastfeeding when supplementation occurs, let's say after all the counseling you've done, okay, mom's going to do this, or there's a medical indication and you haven't been able to turn the bus around, and for right now, this baby, we've got to prioritize calories and volume. That's fine, but encourage skin-to-skin time. We need to make sure that as this formula is going in, that mom's supply is not decreasing. Babies who are skin-to-skin will feed more often, and skin-to-skin raises mom's oxytocin levels, which is one of those breastfeeding hormones, which is good. Have her hand expressing or pumping every time the baby gets any formula. Make sure a lactation consultant or professional, somebody with training, is involved to help them through this. Have a clear endpoint. You don't want a baby who needed it for a couple days when they were 3 or 4 days old coming back to you at 4 months saying, well, we're still breastfeeding and bottle feeding because I never did make enough and that's what he needs. If you can make a couple ounces of milk, you can make 20 ounces of milk. You can make milk for quintuplets as long as your body's getting signaled appropriately. Limit the amount, so we don't want 2 ounces going in if the baby would have only taken in an ounce of colostrum in the whole day. Consider the use of a hydrolyzed formula and consider, like we talked about, the alternate feeding method. So what if mom and baby are separated? What if her baby goes to the NICU? Or what if the baby is readmitted to the PICU? Or what if another sibling is readmitted or a family member and baby's at home away from mom? What is our role there? Well, the important thing here is it's a time-sensitive message. So within the first hour of birth or of separation, you really want to get mom on an expression routine. Probably the easiest thing to do would be the dual electric pump, but you can see the mom's hands here. The best way to do it is with hands-on compression, and then that has been shown to increase milk volumes and maintain signal. If the baby is a little bit older, it's not the first hour after birth when the separation occurs, then you'd want to time the starting of this with the timing of that next feeding that would have been due and sort of keep up that schedule. There's a minimum of about 8 to 10 times a day of signaling to establish a full milk supply or maintain a full milk supply. So 8 or more in 24 hours, 8 or more in 24 hours is sort of the mantra. It does not have to be every 3 hours on the dot, so you can counsel moms to do it more frequently before they go to bed, have a stretch of sleep at night because they're in a stressful situation and their bodies need it, wake up, pump a little more frequently during the day. Moms who smell their babies, are near their babies, at the bedside of their babies, holding their babies skin to skin, make more milk when they're expressing. So think about all those things. And when you talk about it, it's very tempting to be like, oh, this is so stressful, that's just one more thing to add to what she's worrying about. I don't want to put anything on her. Actually, it's the exact opposite. Oxytocin is the love bonding hormone. It has relaxation anxiolytic properties. It has blood pressure lowering properties. It has decreasing blood loss properties. So this is the one thing that a mom who's feeling very scared and helpless can do, to be doing something for her baby. She's the only person that can do this. And so actually getting her pumping, getting dad involved, that we have stories of getting called down to the surgical ICU because there's been a horrible complication from placenta accreta, and dad is the one who's doing the pumping for mom because he knows that she wanted to breastfeed. She's intubated and sedated right now, but this is what she wanted, and he feels good that he's able to contribute. So think about all the players on the team. This is actually, I love this picture because here's a guy, I don't know, maybe walking down the street, you'd think he was into this or not, who knows, but this is the first pumping of a mom whose baby went to the NICU. So they make the most colostrum in the first hour after delivery. You really want to catch that. That's phoning in your order for future supply. So the timing is very important, and you will see more colostrum, probably not that much, but more colostrum the sooner you do it. And then there's no question, like we talked about, that for premature babies, there are even more reasons to use human milk. Necrotizing enterocolitis, late onset sepsis, shorter length of stay, easier and faster establishment of full feeding. So how can we become more breastfeeding friendly in our daily work? Think about wherever you are having a policy. Maybe it's you and the other subspecialists on your team saying, you know what, let's follow these recommendations and let's support moms. Or I'm a cardiologist, I'm actually giving a talk at a cardiology conference in the spring. And every time I'm on the phone and I hear about a baby with congenital heart disease that's going to be coming into our hospital, I'm going to talk to the bedside nurse and tell her to get that mom pumping. Or I'm going to talk to dad about bringing that milk in, or grandma, or whoever's there. Maybe you're in an office practice and if a breastfeeding mom calls and that baby's less than X weeks, they're getting an appointment today. That's a work-in visit. You know, anything like that. Think about your environment and how you can be more adaptable to these situations. Obviously, you want to educate. It might be the first time you meet the mom, baby's already born, but she's never heard this stuff, so it's worth a try. If you have the luxury of being involved in the prenatal clinics, you're seeing a baby because the fetal ultrasound was abnormal, talk to moms about this and plant that seed. And every time you see them, talk about ways in which you're going to help support that. Recommend exclusive breastfeeding. This is not Coke or Pepsi, so get comfortable saying, you know, we really think this is important, or here's why I think this is really important, or we used to think it didn't matter, or you can't tell walking down the street, but here's what we know now. Welcome breastfeeding in the waiting room. Make that very clear, but also provide a private space if people want that. look at your waiting rooms and look at the patient education material we're handing out, and please make sure it's not corporately sponsored. Don't send the mixed message. Don't do free advertising for the makers of these products. It has been shown that mothers who are exposed to advertising, who are given free formula, guess what? They have a shorter duration of breastfeeding, and they are less likely to exclusively breastfeed. Commend them, encourage them, set an example, be involved in the community. Support payment for cost of care and supplies. The Affordable Health Care Act does contain clauses that pay for lactation support and breastfeeding supplies. So now, through our WIC office, all the moms with Medicaid have access to breast pumps or nipple shields or supplies that they might need. And insurance companies are now paying for it. It's very important, though, because it's very variable what types of pumps they pay for and when, and can they rent them or buy them, and where. So moms should call the number on the back of their card if they have private insurance. Start tracking the rates in your practice, whether you're a cardiologist or an office-based practice. How many of our moms are breastfeeding at that first visit? How many continue? How many are still exclusive? How close are we to those Healthy People 2020 goals? And just a shout out to my colleague Sharon Corvo, who is a doctor, nurse practitioner here in Northern Virginia in Leesburg, and also an IBCLC. For her DNP project, she looked at implementing all of these recommendations for a breastfeeding-friendly office practice and studied it. We got it published in Pediatrics in 2013, and we showed increased initiation in her practice and increased exclusivity once they implemented these changes. You are very lucky to have people like Jenny Tender and Sahira Long and Michael Young in your community, and the DC Breastfeeding Coalition is one of the strongest that I've heard about across the country. Very nice online resource, very comprehensive, whether you just want tips for management or how can I get help locally. So does it make a difference? Absolutely. It has been shown over and over that what we do and say about feeding is listened to by mothers and impacts their success. So what can you change tomorrow? And that's all. I'll take questions. Thank you.
Thank you so much. That was a wonderful and important talk. I had two questions for you. One is, can you speak to the rare instance in which we should not be doing breastfeeding? Of course, I know about HIV, but
sure.
There may be a few others. And then secondly, can you speak to whether there are any significant differences between expressed breast milk and natural breast milk?
Great question. So to address the first question, there is a list of contraindications to breastfeeding. It is a short list, but it does include HIV positivity. In the developing world, they have changed those recommendations, but still in the United States, if you are breastfeeding, it is not recommended, or if you have HIV, it's not recommended that you breastfeed. Illegal substance use, active varicella in the mom, not shingles, but primary varicella infection, active tuberculosis, HTLV1, illegal substance use, if I didn't say that. So very, very short list. And again, the AAP statement, breastfeeding and the use of human milk, has those, and also the Academy of Breastfeeding Medicine and the CDC website. So if there's any question, it's very good to check. Of note, hepatitis B, C, A are not contraindications. Most maternal medications are not contraindications. There's a short list of those, like a chemotherapeutic agent or a radioactive agent, things like that. The second question. Okay, so this is fascinating. So in one of the recent surveys, about 30% of breastfeeding moms or more are at some point during the course of breastfeeding pumping their milk and giving it to babies. Couple things about that. When I have a mom say, well, I think I'm just going to pump my milk because I don't really like doing this, and I say that's great. And we know that human milk is absolutely better than formula, and any breast milk is better than no breast milk. It does it is associated with shortened duration, and I think it's because even though people think about breastfeeding in the first couple of weeks as hard and time-intensive, afterwards it's, wah, are you hungry? Plop. And you don't have to mix up all this stuff and sterilize everything and get it ready, and there's a lot of equipment involved, and then moms have to pump for, you know, however long it takes, 10, 15, 20, sometimes 30 minutes, and then feed the baby. That's very difficult to do. It's very difficult to do in public. We have no data other than shortening breastfeeding duration about what does that do for the bonding process and IQ and this give and take of mom versus baby. We don't know. We do know that when you freeze breast milk, so let's say you're going back to work, the living cells die, for example, and some of the substances that we think of as protective are not as good, but pasteurized donor milk in the NICU is still better than formula. So it's a graded thing, and I think on the spectrum of motivational interviewing, I'd take that over stopping completely, but we don't know exactly what the effects are.
Okay. Thanks for a great presentation. And I think much of this is really sort of useful in terms of identifying how, on an individual, mom-by-mom basis, we sort of employ strategies. Part of what we're also, I think, looking at as pediatricians and as children's hospitals is from a population health and a community health outcome, what are strategies that, beyond breastfeeding advocacy, that are impactful at actually altering outcomes and improving strategies. And in particular, we're not just a hospital. We do a lot of primary care. We take care of half the vulnerable kids, Medicaid-enrolled kids in the district. Moms are messaged all the time, and we have found that particularly for the African-American moms in our community, they arrive at the birth hospital without an expectation to breastfeed. And our families are messaged all the time. I'm just trying to, is there data around communication strategies, successful community messaging campaigns, early home visitation, extended parental leave? Are there other strategies that are employed at a community or population level that somehow are creating an environment that produces better outcomes?
So I think you just listed a lot of the things that come to mind in terms of things I'd be tackling at the community level. We're doing a similar thing in Charlottesville. Of the ones that have been studied, the things I'm most familiar with are if you are exposed to the 10 steps in the hospital, that affects your breastfeeding rates at 3, 6, and 12 months. So changing what we do and say in that very short period of time. So supporting your community hospitals, go in and do a grand round at the birthing centers and get everybody on board with skin-to-skin rooming in. The other thing that's been shown to be really helpful, particularly in low-income populations, is peer-to-peer counseling. So get someone in your waiting room who's been through this. There's funding now for WIC peer counselors, and they're trying to expand that to every state. That's a biggie. The other thing I just want to say from a community level is that it's been studied sort of at the society level. The more sexualized breasts are in a country, the least likely women are to feel comfortable breastfeeding in public. So how can you normalize it? And as pediatricians, we have a very interesting, think about breastfeeding with your 11-year-old that you're checking to see what stage of puberty you're in. Oh, look, you're starting to develop. This is called Tanner stage 2, and this is your body getting ready to feed your baby, and start planting those seeds very early. Normalize it. Do some counter marketing or some messaging because they're being hit with a lot of billions of dollars of ads that this is so great and this is a great alternative and it's close to mother's milk and that sort of thing. So counter some of those messages and send the message very early to young girls that these are there to feed your baby. These are not a sexual object. One more?
The world of neonatology is dealing with the marijuana issue, and we really don't know what to do. You know, what we do in our NICU is talk to the mother and counsel her, and then if she says she's not smoking anymore, we take her word, but so we give her the breast milk. But we know it has a huge effect on brain development, and it's getting legalized more and more and more. And I really worry about this because you have to accept that they're not going to use it, but stress comes. And
yeah.
Do you have any thoughts on this?
Well, I think that you're raising a really good point. We were just talking about this last night at dinner. The Academy of Breastfeeding Medicine does have a policy statement about this that I encourage you to look at. And basically, we do think there's enough data to say you probably shouldn't be smoking marijuana, particularly routinely, while you're breastfeeding. And there's enough data in the adolescent brain as it's growing and developing that there are changes that you can actually measure. Very little gets into the breast milk, so the dose that the baby is getting is much, much lower than what the mom is getting, but it is a substance that sticks around in your body for a long time. What we do is we ask about frequency of use and we look for other risk factors. So if this is a mom that has been smoking, 3 blunts a day for her entire pregnancy, despite being told at every visit, this isn't a good idea, you shouldn't be doing this, then I'm much more concerned about encouraging her to breastfeed than I am that every now and then I'm at a party and somebody hands me a joint and I smoke it. So I think taking those things into account, is this a setting where I am self-medicating an underlying illness, or am I incapacitating myself to the point where I'm not going to be a safe caregiver for this baby because of my use? Those are all things that I take into consideration when I'm talking with them, and then we document that we do not think this should continue and that we encourage breastfeeding as long as she can avoid use right now. So that's what I've got for you so far. It's another instance where we're not going to have an RCT. You're going to smoke pot while you breastfeed, and you're not. We're just going to watch your baby. We're not going to have that, so we can get as close as we can get. One more?
I can tell it. Is there
for WebEx.
Oh, for WebEx. Is there any information yet on telemedicine being leveraged as a modality to improve support for new moms and generate any different results?
I don't know of any studies, but I can tell you in the past year we have started doing telemedicine visits. So for us, it's our telemedicine program, yet they have to live in the state of Virginia, but there's something like 124 sites across the state. It's tricky, but it's doable. We had myself and a lactation consultant. We have a camera that we controlled, and we could zoom in and see the latch and hear swallows. It was really quite amazing. So I do think that that's coming in the future. I think we're going to have to be careful, just like we are with any kind of other providers providing care and not being present physically with documentation and with licensing and credentialing, but I do think there's a place for that. And one of the lactation consultants that I love says that 95% of the time in breastfeeding medicine, you're walking in and you need to send the message that you're doing something wrong and we need to tweak it, but while empowering the mom and making her feel good about this and making her feel as she is the expert on her baby. And half of that is you've got this empowering, what are your concerns, let me hear them, just have a chance to tell me about them, and let me tell you why I'm a little less concerned about that, and here's what I think we can do, and you've got this, and we're here for you. So a lot of confidence building and support, and that can easily be done via a camera.
All right, so I think we have to end, and thank you so much. That was really inspiring and informative.
And by the way, I didn't mention, but hopefully you'll get these slides. I did include a lot of resources at the end that I have found very helpful in this journey at our site.
And for anyone that wants a little more, Dr. Kellams is going to be doing a webinar at noon on creating a breastfeeding-friendly office, and then at 3 o'clock we have a neonatologist coming to talk to the NICU about breastfeeding the premature infant. Thank you.